Hi guys, welcome back to Code Master Coach, your medical coding tutor. We're continuing our studies on risk adjustment, guys, and today we're going to talk about risk adjustment models, starting with Medicare. Medicare is available to U.S. citizens who reach 65 years of age. Part A is free. Part B can be purchased at a relatively low rate and is administered by Medicare's administrative contractors, or MACs, under the guidance of the Center for Medicare and Medicaid Services, CMS. Traditional Medicare's Part A and B covers 80% of costs, and enrollees are responsible for 20%. Part C is Medicare Advantage, which covers Parts A and B. Part D is a prescription drug coverage. It's administered by private insurers that process claims and pay with federal dollars. Some programs merge Parts C and D for Medicare Advantage coverage. Let me give you a little bit of history. Medicare Plus Choice was developed under the Balanced Budget Act of 1997, was the first risk-adjusting plan. The Medicare Prescription Drug Improvement and Modernization Act of 2003, also known as the Medicare Modernization Act, replaced Medicare Plus Choice with Medicare Advantage. The MMA also created Part D. Medicare Advantage is a type of Medicare health plan offered by private insurers that contract with Medicare. Participating insurers are called Medicare Advantage organizations, or MAOs. Enrollees must be eligible for Medicare, and CMS Medicare coverage rules apply to MAO plans. However, MAOs sweeten these plans by offering extras, including out-of-pocket maximums, health club memberships, and prescription coverage. In exchange, MAOs charge a fee that is added to the normal monthly Medicare costs for Part B. Let me give you an example. A Medicare hospitalization for coronary artery bypass graft, also known as a CABG. So the cost for the hospital, the surgeon, and other costs associated with a CABG in 2017 was $75,345. Medicare pays $60,276. A Medicare patient would pay $15,069 if the patient has traditional Medicare coverage and no supplemental or secondary insurance. So many Medicare Advantage plans cap the out-of-pocket maximum. Today, 1 out of every 3 Medicare participants is enrolled in a Medicare Advantage plan. Risk Adjustment Factor, RAF, is a score assigned to an enrollee in a risk adjustment plan. For Medicare Advantage, the Risk Adjustment Factor score is based on ICD-10-CM codes associated with the patient during the previous calendar year. So diagnoses from 2017 are used to create the patient's 2018 Risk Adjustment Factor score. The Risk Adjustment Factor score determines the monthly payment to the Medicare Advantage organization. So a patient with multiple comorbidities will generate a higher payment than a patient with fewer comorbidities, as well as be associated with more office visits, hospitalizations, tests, and prescriptions. But what were some of the unintended consequences? Poor outpatient diagnostic coding due to few ICD-10-CM audits in the past. Upcoding of conditions, for example, coding from past medical history. As a coder, we try to document or code anything that we can on that patient. So downcoding of conditions can also be a problem. Failing to code documented causal links. So if the physician didn't tell us that the neuropathy was due to diabetes, we didn't capture it. So under documenting conditions, the physician didn't document it. That led to non-specific codes being reported, or not coding all diagnoses because comorbidities were not the reason for the encounter. We just coded what they came in today for. The other comorbidities weren't documented. We didn't code it. MAOs are held accountable for codes submitted by physicians within their plans, but don't control documentation or coding. So, MAOs are offering clinical documentation improvement initiatives for diagnoses. MAOs are hiring auditors to review chart documentation. So the focus becomes on the money codes. CMS created these HCCs to report risk associated with required medical resources and prescriptions. So they have prescription HCCs for risk associated with prescription drug costs. There are about 9,000 diagnoses that map to 80 HCCs and about 4,000 diagnoses that map to 75 prescription HCCs. Some ICD-10-CM codes have only HCCs or prescription HCCs, and some have both. Most represent chronic conditions, although some acute conditions, for example, pneumonia and hip fracture, also risk adjust. So let's look at an example. When two related conditions are diagnosed in the same year, CMS requires that only one of the conditions be counted toward a risk adjustment factor score. Coders still abstract all conditions, but CMS may drop some from the RAF's tally. There are tables used by CMS to determine which code is valued for the risk adjustment factor. So in coding language, this is sometimes called trumping, as in diabetes with acute complication is trumping diabetes without complication. Synergistic disease. Sometimes the interaction of two diseases is worse than the sum of each disease separately. For example, both congestive heart failure and chronic obstructive pulmonary disease compromise lung function. The two together, however, have worse outcomes. These interactions are another reason all diagnoses documented during an encounter should be reported. So with submission to CMS, a Risk Adjustment Processing System, RAPS, is a data center for CMS, and MAOs are permitted to submit diagnostic updates to the system. These updates are corrections. MAOs review claim data and determine if diagnoses are missing from the claim of patients with long-standing chronic conditions. MAOs may commission risk adjustment auditors to review physician or hospital coding to determine whether ICD-10-CM diagnostic coding was correct and complete. The claims are updated during certain time periods called sweeps. Remember, MAOs are held accountable for the content of physicians and hospital claims. Risk adjustment data validation is a CMS audit of claim documentation. This is performed to determine whether submitted diagnoses are present. So during a risk adjustment data validation audit, the MAO will be asked to submit a copy of documentation to validate a diagnosis. These risk adjustment data validation audits are time intensive. Patient demographics and administrative issues, such as signatures, are a consideration in these risk adjustment data validation audits. CMS extrapolates repayment across all claims to determine the payment error rate when a diagnosis is not validated, so stakes are high. They have what's called a 5-star quality rating. Star ratings are incentives to MAOs to promote quality of care and services within their provider groups by tracking prevention metrics and patient satisfaction. Star ratings translate into bonus payments for penalties for MAOs. Star ratings are made public and can be used by consumers in their health insurance decision making. Risk pools are health exchanges created by the Affordable Care Act. Diagnoses risk adjust according to the HHS HCC model. You have an HHS HCCs that are similar to the CMS HCCs, but the HHS HCCs include perinatal and obstetric diagnoses. Documentation and coding is validated through an initial audit validation performed by auditors selected by the risk pool insurance company, and then secondary validation audits are performed by auditors selected by HHS. This ensures the integrity of the system. So, the risk adjustment goals are to direct clinicians to focus on resource-intensive chronic conditions and preventive measures to drive down complications and costs, improve the quality of documentation and coding of diagnoses, which are key to evidence-based medicine, and to offer more choices in medical insurance. So guys, we see where risk adjustment's going. It's going to be to our advantage. As coders, it increases our jobs. Not only do we code up front, but then we're asked to come back and be risk adjustment coders to go back and view the previous year's charts to make sure that these chronic conditions were captured and coded. It's going to drive the physicians to improve their documentation, because these insurance companies are going to put stipulations on these physicians who don't document what needs to be documented so that the coders can capture these diagnoses. And it's going to offer more choices in medical insurance, because now the insurance companies will be able to handle these patients with these chronic conditions that in the past couldn't afford to handle them. So, okay, guys, we're going to continue. Our next video, I'm going to be showing you an actual risk adjustment data validation medical record checklist and guidance. So stay tuned, guys. All right, that's it for today. Thanks. I will see you in the next video.